In this video I'm going to talk about tuberculosis, and actually tuberculosis is a chronic infection of lifelong duration. Okay, what do we mean by chronic infection? It means that tuberculosis lasts for about 8 to 10 months. Okay, 8 to 10 months and up to 1 year. Okay, and once the tuberculosis in the body, it may last for the whole life. Okay, maybe asymptomatic, but the bacteria are in the body. Tuberculosis actually is a huge disease. It affects a lot of people. About 10 million new cases every year are happening. Okay, 1/3 of population are affected by tuberculosis. So it's a serious health problem. We have to understand 3 million deaths of tuberculosis every year. Okay, some areas are having much more tuberculosis rather than other areas. Okay, for example, Africa has a very high incidence of tuberculosis. Is an HIV killer there, HIV/AIDS. Okay, so I want you to know that there is some concordance between the HIV and the TB, and TB is killer in HIV patient. The microorganisms, actually the most important microorganism to cause tuberculosis are Mycobacteria tuberculosis. Okay, also we have the Mycobacteria bovis, but it rarely causes tuberculosis. Tuberculosis is mostly caused by Mycobacteria tuberculosis. Mycobacteria tuberculosis is a pleomorphic, weakly gram-positive rods. So you can see the rods here. Okay, it is a gram-positive bacteria, aerobic, non-motile, non-spore forming. So it is not motile, non-spore forming. Okay, the Mycobacteria, what do we mean by myco? Myco is Latin for fungal, but it is a bacterial infection. Why do we call it fungal, myco? Because it has a very slow growing pattern, just like fungi. Okay, it takes about 6 to 8, or in some books 4 to 6 weeks to Mycobacteria tuberculosis to grow on a plate, and it needs additional 4 weeks for drug susceptibility. When we talk about the investigations tuberculosis, you will see that this will stand as a problem when we diagnose tuberculosis, because it takes it a lot of time to grow. Okay, it takes it about 15 to 20 hours for doubling. So let's get back to the definition of tuberculosis. Pleomorphic, have many shapes, weakly gram-positive rods. So rods, gram-positive, aerobic, non-motile, and non-spore forming. Something distinctive about tuberculosis: it has very thick and dry cell wall. What is the secret behind the very thick and dry cell wall of tuberculosis? Is the presence of mycolic acids, the fatty acids, on the cell wall of tuberculosis, of the Mycobacteria tuberculosis. Okay, and the presence of mycolic acid, the fatty acid on the cell wall, makes it very difficult to be killed. Okay, it can be killed by heat, but it can tolerate dry, humid, and other weathers. Okay, so the difficulty in killing tuberculosis make it in need to combination of treatment. One drug is not enough to treat tuberculosis, need more than one drug, and this is due to the mycolic acid, fatty acid in the cell wall of the tuberculosis that make it very strong. Okay, it also resists destaining by acid alcohol after being stained by some dyes. Okay, so we add a dye to a culture of tuberculosis. Okay, the cell wall that have mycolic acid will resist destaining. The dyes that we add usually destain the bacteria, but if we have a Mycobacteria tuberculosis, it will be not destained. Okay, and that's why we call it acid fast bacilli. This is the acid fast bacilli. Okay, here is the Mycobacteria tuberculi. It were not able to be destained, as you see. What are the dyes that we add to the tuberculi or to Mycobacteria tuberculosis to test it? We add Zehl-Nielsen dye or Kenyon stain, okay, but these two does not distinguish TB Mycobacteria from non-TB Mycobacteria, okay. So Mycobacteria may cause other things TB, okay, but the Zehl-Nielsen and the Kenyon stain cannot distinguish the TB and Mycobacteria from the non-TB one. So we use the fluorochrome dye, which is the easiest and the best way of diagnosing such things, okay. So my method of explaining tuberculosis in this video will not be by mentioning the risk factors, going over the pathology, the clinical manifestation. It is a story, and I want to start this story from the beginning. We have somebody around that is infected by Mycobacteria tuberculosis. So this person is okay. So this person is affected by TB. Okay, he has TB, and this person is free. When this person, the patient, sneeze, cough, laugh, or breathe, or doing anything like that, okay, the air droplet of TB will move to the other person and go to the lungs. So the TB is mainly transmitted via airborne droplet. Okay, we have airborne droplet nuclei that contains tuberculi bacilli, and this is the main way of transmission. It may stay in the air for hours after patient leaves. So somebody with tuberculosis may cough, okay, and the tubercular bacilli will be in the air for hours even after the patient go away. Okay, even if he goes away, the other patient or the other normal person may be in the place and may have the infection from this one. Okay, so mostly adults are the infectors of tuberculosis. Why? Because children have not the ability to cough effectively and expel the organism just like an adult. Okay, so mostly adults are the infectors of tuberculosis. The presence of something will increase the susceptibility of tuberculosis. Like what? Like the decreased immunity or immune deficiency, like an HIV virus infection. Okay, so as we said in the beginning of the 80s, okay, there were an endemic increase in TB. This is due to the presence of HIV in huge numbers. Okay, chronic medical disorders also is a risk factor for transmission of TB. Prisoners or a crowded area like school bus, like work areas where we have those people, risk factors. Low socioeconomic class, the drug abusers, malnutrition, healthcare workers like nurses and doctors are all susceptible more than other people to have TB. So decreased immunity, chronic medical disorders, low socioeconomic class, prisoners, crowd area, healthcare workers, malnutrition, and drug abusers. Let's complete the story. The patient sneeze, cough, laugh, breathe. Okay, the normal person will inhale the droplets that were in the air. The alveoli immune macrophages engulf the Mycobacteria and replicate it. So once the patient or the normal person inhale the bacteria, the macrophages will engulf this Mycobacteria and replicate it. This is a primary TB. Okay, let's see this story by eyes. So after the macrophages eat the bacteria, we have three possibilities for that, for the after scenario. The patient may healing totally, okay, if we have no enough immunity, okay, and macrophages, like in neonates they have less immunity than adults and older children, okay, we will have what we call active primary Tb. Okay, if we have enough macrophages that engulfs that bacteria, the macrophage will engulf all bacteria, then the macrophages will die, and the collections of macrophages and the organisms and the dispersed and lymphocyte will constitute what we call granulomas. Okay, and the granulomas are called the Ghon's spot. If the Ghon's spot are in the lung plus in the lymph nodes, then we call it the Ghon's complex. Let's get back to the scenarios. The first scenario, to have totally healed patient. The second scenario, to have no enough immunity and no enough macrophages to phage all the Mycobacteria tuberculosis. So we will have active TB. Active TB will be symptomized. TB symptoms are more important, okay? If we have a lung TB, just lung TB, usually it affects the apical segment of the upper lobe or superior segments of the lower lobes. You know, the lobes of the lungs, okay? The TB usually affects the upper segment of the upper lobe, and if it affects the lower lobes, it affects the upper parts of the lower lobes. If it affects the lung, we have constitutional symptoms and we have pulmonary symptoms. Constitutional symptoms like low-grade fever, like malaise, night sweat, and weight loss. Pulmonary symptoms just like productive cough and hemoptysis. When you see productive cough and hemoptysis, held cavitation and bronchial erosions. So hemoptysis is associated with cavitation and bronchial erosion. We may also see pleural effusion, and this pleural effusion may represent the immune response to infection. Okay, so lymphocytes and the immune response to infection may be exposed to pleural effusion. If you take a pleurocentesis, you will see lymphocytes and increased proteins, but no bacillus are seen mostly in the pleurocentesis. Okay, so this is if we have a pulmonary tuberculosis, constitutional symptoms and pulmonary symptoms, and the most common tuberculosis are pulmonary tuberculosis. Okay, the TB also may extend to the lymph nodes. If it is in the lymph node, we can see hilar lymph adenopathy or Ghon's spot. And I told you what is Ghon's spot. It's a macrophages plus the Mycobacteria tuberculosis, okay, and some lymphocytes. It is the Ghon's spot. Okay, if it affects the lymph nodes, we can see low-grade fever, symptoms due to enlargement of the lymph nodes, and skin lesion, erythema nodosum. It may affect also extra thoracic lymph nodes. Like what? Like cervical lymph node, like supraclavicular lymph node, and supramandibular lymph node. Scrofula is the name of the lesion or the enlarged lymph nodes in this case. So scrofula is enlarged lymph node and TB lymphadenopathy. Okay, so if it can affect the lung, can affect the lymph nodes. What also? Okay, we can also have a widespread hematogenous dissemination of the TB to multiple organs. This is what we call miliary TB. What are the symptoms of miliary TB? All miliary TBs has constitutional symptoms in most of cases, okay, plus the distinct organ that is affected by the TB. Okay, you may see bilateral miliary infiltrate in the lung. Okay, on radiograph you can see this. And the miliary infiltrate, you know, the millet spots or the seeds of the millets is حبوب الذرة البيضاء أو الدخن هي is the cause to name the miliary dissemination due through blood hematogenous or miliary TB. Okay, in the tuberculin skin test it may be negative in miliary TB. Why? Due to anergy. What is anergy? It is absence of immune response. Okay, so what to do is to have liver and bone marrow biopsy in these cases. It's very useful. Okay, so let's back. Miliary TB. It is a widespread hematogenous dissemination to multiple organs, manifested by constitutional symptoms plus the symptoms of the distinctive organ that the miliary TB may affect. Let's start with the CNS symptoms. May affect the meninges, causing meningitis. In meningitis, CSF will be very high protein and low glucose. It is a bacteria infection, and bacteria infection we have low glucose, but has much higher protein numbers. Okay, we have to do culture to diagnose meningitis due to TB. Okay, in this case CSF culture is not diagnostic, you have to do blood culture or PCR to diagnose. This is about the meningitis in TB. Also miliary TB may affect the skeletal system. Okay, so we have skeletal TB. This can be by hematogenous spread or direct spread by the caseated lymph. What do you mean by caseated lymph? I told you about the granuloma. If you open up the granuloma, you will see a necrosis in it, and this necrosis is just like a cheese. Okay, so it is caseating necrosis, and the caseating direct lymph spread to the bones is one of the path to spread TB to the bone. Okay, in bones we can see cortical destruction, just like in osteomyelitis. And how to distinguish between the cortical destruction in osteomyelitis and due to TB? You have to take a biopsy. Just biopsy is a diagnostic in this case. In spine we can see Pott's disease. Okay, and the spine is the second most common area to have TB, just after the hip, okay, and fingers and toes. Okay, so hip, fingers and toes. Then we have the spine to be affected by TB. Also we can have abdominal tuberculosis. It is rare, but we can see an ascites and abdominal pain due to abdominal tuberculosis. Okay, so these are the symptoms of the TB when we have primary or active tuberculosis infection. Okay, so remember we have pulmonary TB and other things. Let's get back to the latent TB. When we have enough macrophages that engulf the bacteria and preserve it in, so we have a latent TB. Latent TB is asymptomatic stage of TB with negative chest X-ray findings. Okay, but we have positive tuberculin skin test. Okay, so we have no symptoms, but actually we have a TB. In active primary TB we have symptoms and we have positive test of TB. Okay, and the no symptoms is due to macrophages engulfing of the TB, forming a granuloma that protect the body from TB for some time. Okay, it takes it some weeks in children and maybe decades in adult to TB to get rid of the macrophage and to disseminate and cause the symptoms. Sometimes it never manifests. Okay, if we have a TB after a latent TB, if we have symptoms of TB after latent TB, okay, it is secondary TB, okay, secondary TB. Fever of unknown origin is very important symptom of TB. So to conclude, we have 3 stages of TB. The first stage is the exposure stage. Okay. In exposure state, we have no signs or symptoms, okay, no or negative lab test of TB, okay, negative X-ray, chest X-ray findings. This is the first stage. We have infection, okay, this is bad. Infection stage of TB. Infection stage of TB, we have also no signs and symptoms. We have positive lab test like skin TB, tuberculosis skin test, okay, no X-ray finding, and this is what we call the latent phase of TB, latent TB, asymptomatic stage of TB with no symptoms but with positive tuberculin skin test. This is the infectious phase stage of TB. The exposure, the infection, and the last stage is the active disease. The active disease, just like the active primary TB, okay, we have the signs and symptoms of TB, we have the positive lab tests of TB, and we have the positive X-ray, chest X-ray. So this is all I want to talk about in this video. In the subsequent video, I'm going to talk about other things like the diagnosis of TB, the complications of TB, the treatment of TB, and the how to prevent TB. I will let you know with this video.
TB, also known as tuberculosis, also known as TB, is spread through the air from one person to another. When someone with pulmonary TB disease coughs, TB bacteria are expelled into the air in tiny water droplets. These droplets can remain floating in the air for several hours, making it possible for someone nearby to inhale them. Once a person has breathed in droplets that contain TB bacteria, they travel down the trachea and enter the lungs, where they collect in the alveolar sacs. Once in the alveolar sacs, the bacteria begin to multiply. The body's immune system starts working and macrophages begin to surround the bacteria. A granuloma is formed to keep the bacteria from spreading. The TB bacteria remain in the lungs, but the body is protected from disease by the granuloma. In 8 to 10 weeks, the person will most likely test positive for latent TB infection. The progression from latent TB infection to TB disease occurs when the granuloma break open and the TB bacteria multiply. Then the person becomes sick with TB disease and may be infectious. This progression can occur immediately after infection, many years later, or not at all. When the TB escapes from the granuloma and begins destroying a person's lungs, it's called pulmonary TB. TB bacteria can also enter the bloodstream and travel to other parts of the body, causing extrapulmonary TB.